the more I structure it, the that for me. He has his own little animation studio up in somewhere north of Boston. I can never remember where he is. All right, folks, we are live here with Kevin Mulcahy, as advertised, ready to step into the ring. Did you see the advertisement?
I did. I really liked the image that you took of my profile and made that old guy looking like this. I was like, okay,
It was
not me, but very close.
I do my best. I know there's no one that I think I've done worse than Charlie Zanazzi. There's been a couple of other people who have been very upset with my AI depictions. I don't invest a lot in my AI, I guess.
No, but it is amazing what AI can do.
It makes it possible for something like this, because
Right.
I mean, this whole thing probably cost me about, I would say, in the area of $3 to $4 grand a year to run. And I'm not getting income. I'm not doing sponsorships or anything yet. I mean, if you're interested, you can contact me. No, but it's a fun gig, and I think, but I have to keep the expenses obviously very low for this stuff. So I think
Sounds like a healthcare practice.
Right. God. I think I last saw you at the HLA conference up north, which was actually not that long ago. Did you partake? You didn't partake in the bourbon night, did you? Were you there?
I did not.
No.
I was.
Did you know about it? It was kind of like impromptu.
I knew it was happening.
Yeah.
I didn't know where. Somebody had said it was in somebody's room. Somebody said it was in the lobby.
That was all my fault. I did not make my decisions well.
But I heard that it was a good time and that there was some good bourbon tasted.
We had, I think, 6 or 7 of them. 6 or 7 of them, and it was I got one that I didn't realize was powerful, and I thought I was kind of like a wimp. I take a glass and I go back, so I wasn't near my bottle, and I was like, woof. But I think it was 114, 115 proof, somewhere around there. I'm like, okay, good. That was actually some.
What is your preferred bourbon?
Well, that was called Noah Hill. I would say for bourbon, I mean, I hate to sound lame, but I'll tell you this. My favorite thing to do with bourbon is a Godfather. Have you ever had a Godfather?
No.
It is, of course, being Italian, I'm required to. You get the big ball of ice, like the fist size ball of ice, so it doesn't melt. And you have it basically 50-50 Di Serono.
Oh.
With, I like Eagle Rare goes really well with that. So that's my favorite bourbon drink. It's the only time I will drink ice with any kind of whiskey. Okay. I can't. I don't think it's proper. I think you always have to have it neat otherwise. But like the classics, like the Jeffersons and stuff like that. That's kind of where I go.
Nice. Yeah. Fun fact about me is I work at my buddy's liquor store 2 nights a week.
Oh,
so
interesting.
Very interesting to see what people drink from a bourbon perspective and what they're looking for. They're always looking for something high end, but then they see the price and they're like, I don't think so.
Yeah. Well, it's fine because I mean, I think I prefer Scotch over bourbon. But like, so Glenlivet, the 12-year, I think is swill. The 15 is amazing. The 18 is even better, but it's almost twice the price. So I fall into the 15, and that's my sweet spot. So
nice.
You got to figure out where it all fits. Anyway, so HLA was an awesome conference. You spoke there. What did you speak on over there?
I spoke about networking and the power of networking and how it can help an individual just to continue to meet people. Because as you know, I'm transitioning right now into something new.
Right.
And so I was taking the opportunity to share my experiences over the last couple of years as a older male, late in my career, and trying to deal with change, and showed them examples of the power of a network.
Yeah.
And, when I had to engage my network again earlier this year, I had to come up with those strategies and figure out what exactly it is that I'm looking for, who can help me. And it really was just very powerful. And there's so many people in different points in their career that all I tried to do was tell them that it's one thing to have a LinkedIn profile. It's another thing to use your LinkedIn profile to stay engaged with your network.
Right.
It is important from the perspective to let people know what you're doing, things you've accomplished, it's not for the happy birthdays and those types of things.
I hate
And
those. Yeah.
yeah,
I think LinkedIn's always seems to be trying to find its own identity, and people are notoriously terrible with their LinkedIn profiles.
yes, yeah,
And I think it also comes off very like braggadocious though. It's like usually like if you're posting, like you just said, it's you want to put up you just got a certificate, you just got a new job, you just
right.
did that. And so it's all like me, and it's kind of hard not to. I think some people like don't want to just go out there and just brag about themselves.
And that's where I told people that they just need to make sure that, a post on LinkedIn is one thing, but an email to your network
Yeah.
is more powerful from the perspective of they're more likely to remember it.
Right.
And the power with LinkedIn is when you post something that you need assistance with, is you ask your network to repost it for exposure.
Right.
It's one thing just to repost to me, but it's another thing for me to, have Tim DeBona send it to his network.
Right.
And so, I try to do that more. And, a lot of people will just say sharing for exposure and putting out the post so that people understand what's happening. And, I've reconnected with a whole lot of people this most recent go around. And have had some great conversations. I mean, my boss from 28 years ago, Marcia, she, said, "Hey, I'm here to help you." And so
that must be awesome reconnecting with people from your past too.
It is. And, you think about those things when I met her, my oldest was 1.5, and my wife had just called me back when they had, payphones, and we connected, and she told me that, she was due with our second. And, as I went to work for Marcia, she goes, "I can't wait to hear when your boys are teenagers and what you go through." And she had daughters, and it was, they're older now, but it was just great to catch up. And, we haven't seen each other, in 25 years, but, it was great. And there's so many other people that I connected with that just, said hello and, have sent me referrals. But yeah, so to me, the power of networking is really important. And trying to stay engaged with it without being overbearing.
Yeah, I've started commenting on other people's things in LinkedIn. And then I actually got some blowback on one, which, I'm typically fine with because I'm usually not everyone's cup of tea. But I did one. It was really funny because it was a political one. So it was something being released by that I care about. That was about the microplastics. So we have microplastics in our water supply now. We have people know that it exists inside the human body, and it has not been well studied. So Robert Kennedy put out this post about it, and I must have made some comment on it, and then people were like, this is all garbage. I was like, well, nobody can you can debate about what if it's even needed to be removed from our systems because we don't even know the effect it's being had on us. But we can't really argue about the fact that we ought to research this and find out, and probably should have done that 15 years ago. This is a great program. Like anyone in the medical community would be behind, they'd be like, yeah, well, look at the source. And it's like, oh God, it's like, that's why whenever you have like these political things come out, like I remember when they did the, they did the announcement, the Tylenol announcement, which was a big one too. And then you had these women on TikTok taking Tylenol while pregnant, saying, "Oh yeah, take this, Trump," or something like that. And I'm like, why? Why does it get like that? So those things I think are, you don't see that as much. Usually people are pretty respectful and professional on LinkedIn, but sometimes you see people post that controversial stuff, or even if it's not, doesn't seem controversial, it just blows up into that.
It's like family politics. You don't bring them up at the table.
Right.
So you just kind of steer clear of them.
So outside of LinkedIn, because people network in very different ways. Like, I have my Salus networking group that we have. What about you? What are other ways that do you mainly do it with old contacts or like coworkers? Do you formally join networking groups like chambers of commerce?
Yeah, I mean, a long time ago, I joined Kiwanis when I was in New Jersey. It was always kind of interesting to meet up for lunch, but those things have changed a little bit. COVID taught us a lot about networking, And for a while there, people just kind of disappeared. And as Zoom and Outlook, Teams became more popular, that became my phone.
Yeah.
And so I would just, try to, whether it was keeping in touch with my staff or other people within the organization that I no longer saw personally, because what they call a manager by wandering around. So to me, I conducted more business when I'd walk the halls of MGH or and run into people, stop in the emergency room and talk to friends, those types of things, and just get the pulse on what was going on.
Sure.
But with my team, they were at home, loving life, but they would shut down when I would call.
What do you mean?
So they would just be very careful in what they said to me. And so one day in a staff meeting, I had them all together and I said, what is going on? Why aren't you guys responding to me via Teams and participating like you normally do?
Sure.
And so they sat there for a couple of seconds and they said, well, we think you're just checking up on us. And I said, okay. Because one of the reasons was you just saw this influx of emails.
Okay.
Everybody was just communicating via email, which was fine.
Yeah.
But I wasn't being satisfied, for my quest of knowing what's going on. And so I sat there and said, when we were in the office, what did I do? You came into the department and you'd sit down and talk to us. We'd review things.
Right.
I said, what do you think I'm doing now? It's through a computer. It's me sitting at your desk and trying to find out stuff. And so now with clients or other people in these remote or hybrid type situations, I'm really just using the vehicle of Teams. I'll send somebody a note that says, hey, can we set up some time for I'd like to have a Teams, because to me, the visual interaction with somebody's most important.
No question. I think I'm probably cut from your cloth. People here hate me for it because I like the in-person stuff. Everybody loves to work remote. They want to get their stuff done. Nobody wants to have somebody like an ogre over their shoulder watching what you're doing and everything. But we also know that communication is imperative. It improves things. It's very difficult to get metrics on how it improves things, but we all know that it's important to have like that camaraderie for teams to function. And and I think that, I was tested horrible. I had this one employee I remember before, and he didn't like to rock the boat. So he, but I saw his numbers dropping, his productivity dropping, and like, are you not working? But you can also monitor.
Right.
So there's, I guess, reasons for people to be paranoid. But, I'm checking like, okay, they're in there, they're working the right amount of time. Like, why aren't they getting anything done? Finally, I was like, I'm taking your work, I'm reassigning it to somebody else. And that person immediately called me up. I can't work like this, Tim. And I was like, great. Why? And she was like, because all of these files are coming in. They're like sideways. They're all cockeyed. Like, I can't print them. I can't do this. I was like, thank you. This person just felt bad telling me that there was some issue on their side and they were trying to make do. And it's like, no, tell me. And we were talking about that beforehand. Like, my first impression of Kevin was like, we were at an MGMA conference. It was a payer day. And there was some insurance company that was supposed to go up there. And those things, I had heard rumors about those payer days. It was like when did I first get into MGMA? 2014, 2016, somewhere around there. And people are like, Tim, you got to see the payer days. It's like a Salem witch trials. Like, they burn them at the time. I'm like, oh my God. And they weren't huge fireworks, but I think the thing I liked about you was that you kept things on point. So if an insurance company was trying to dodge or something like that, you'd be like, like, don't waste your time. You have 5 minutes or 10 minutes. Like, this is way. And then and then sometimes too, if nobody had a question, you always had a question because you like, so I don't think I really understand this so much. And I do want to get back to the networking thing, but you've always had a very strong relationship with the payers. Your work at MGH, you had over 4,000 positions. So I know rev cycle 1,000 ways on the micro scale. I do not know RCM on the scale that you have managed. So I think that's probably like 50 questions right in there. But like, if you could just speak to what were your relationships like with the payers? Because you must have held a lot of weight, because where you moved, if you were going to unenroll in a payer, that would have a major effect on that payer locally.
Yeah. So my career at MGH was amazing. My entire career has been amazing, and the things that I've been exposed to. But I had been in community hospitals for 7 or 8 years,
Oh, okay.
and prior to MGH, I was with Caritas Christi,
Oh yeah.
and I ran their physician billing company. And
Wait, what years?
I was there I came at the end of 1999 and left in
God.
July of 2002. So Physician
Okay.
Practice Support Inc. was the name of the subsidiary. And so I ran their physician billing company. And shortly after I got there, they said, we're going to have to take this in a different direction.
Mm-hmm.
And so we worked on the closure of it. But we also began working with Athena.
Okay.
And they were very new in the market. And
Yeah.
we didn't want to use it as an EHR, but we wanted to use it as a billing system.
Oh wow.
And so
I would so strongly say the opposite now.
Yeah, now, yes. Yeah. But again, health systems wanted to keep control of their receivables and those types of things. So when I left there, I was like, I think I need some of this academic medicine background.
Yeah.
And I had loved my time in New Jersey at the hospitals that I was with, and loved Caritas too. And I said, I'm going to go over there for 3 years.
Yeah.
And then we'll come back and reassess. Blink of a hat, it was 22 years that I was at MGH. And what MGH made me realize was the medicine side of revenue cycle management.
Okay.
That there is cutting edge stuff happening. The research that's being done to advance medicine was so profound. I met so many clinicians, and it was Dr. Hemphill who was treating apheresis, had a cohort patient population of 15 here in New England with, the patients had cholesterol levels greater than 1,000. Okay. And so, a payer wasn't paying for the service. Yeah. And so I brought them in, and this is pre-HIPAA. So, you could do these types of things. We met a patient, they watched the procedure, and, the payer then left. And, I talked to the patient. The patient, surprised me because she was pregnant. And I was like, if you have this, why? Again, I was in the naive, young guy. And she said, because of this program, I know my child can get access to this. And that started my whole thing about how do patients get to the Mass General? How do they get to these types of services? And so while I was in the revenue cycle department, my component of that was this whole payer relations and bringing operational issues forward. But
I was like, how is he getting to payers here? Because it's interesting that they bring you in on clinical matters like that. And I think it's always good to understand how the entire body of an organization works, because this is why so many places the left arm doesn't know what the right arm's doing.
Right.
But that's great, because that ties in. Not only does that create knowledge, so you don't sound like an idiot when you're talking to them. It created passion, obviously, within you to really make you want to accomplish things. And now you have your direction to go directly to the payer as an RCM person to try to, how do we get this treatment delivered to patients?
So, and I'll just summarize that story, because I was exposed to that. And one day I was in a meeting, and Dr. Lynch, president of the NGPO at that time, talked about apheresis now being available in a drug format.
Okay.
Great. Just locked it away. I'm at an MGMA meeting, networking, at one of the, local establishments, but with a cohort of friends. And they said, how do you deal with the payers day in and day out? And I said, it's because of what my doctors are doing. And I told the story. And shortly thereafter, a woman came up to me and said, can you get me the name of that drug? I'm from Anchorage, Alaska. My husband is not surviving, and he needs this.
Wow.
Sent an email to Dr. Lynch. He gave me the name of the drug, gave it to her. And 6 months later, I got a note from her saying, you saved my husband's life. So to me, it bound me to the medicine side of it. And I always said, I'm going to be that voice
Yeah.
for the clinicians, and made it my job. And it was, hi, I'm Kevin from Mass General. And payers would listen.
Right. Right.
And I took Payer Day as the opportunity because I had access
Yeah.
to those payers. And those relationships over the years have allowed me to continue my conversations with them as I'm now at a different point in my career. You know, I'm still talking to my contacts at Aetna and United and Blue Cross, you know, because I worked very hard at
Yeah.
Payer Day to say, we're not here to beat up the messenger. We're here to voice our concerns. And I always started the meeting with, you're our friends. We want you here. And, you know, back in the heyday, we had 300 people at
Yeah.
Payer Day.
Oh God, yeah.
And, you know, as COVID kind of changed the way we do it,
that really,
you know,
changed everything.
we're trying to figure it out. So
I think
I'm
you
really
even
proud
let
of what
them
I
know
did.
prior. I think you would even let them know prior, like, hey, last year this happened.
Yep.
We're not gonna, you know, because I think the thing too is, it's like, yeah, you don't want to necessarily crucify people, but you do want to hold them accountable. So
Yep.
like, because if someone's gonna screw with your organization, it's gonna be like, I'm not gonna let you tread there. Because I think that's the thing, is that you didn't have a reputation for, I don't want to say not being reasonable. It's that you had a reputation for like don't bullshit a bullshitter type of a thing, where it's like, you know,
Yep.
I'm going to defend you and tell people to
Yep.
relax, that you're
Yep.
doing your job. But if you're going to come here and not do your job,
Right.
now you're
Yep.
going to get Kevin upset, and they would know that.
Yeah. And so, you know, I would always just make sure, because I always looked at it, if MGH has the problem, I know that
Yep.
Mary Ann is going to have the same problem, just at a smaller scale,
Yeah.
and may not see it, you know, because we were constantly looking at denials
Yep.
and payments and, you know, really trying to pull those patterns out, which to me is so very important. And I tried to reiterate to providers that if you're going to have somebody looking at what you're getting paid, you need to have an experienced revenue cycle person doing that, because they'll understand all of the calculations that
Yeah.
take place. So if you just have finance looking at it,
Oh, I love
they're
that
not
you
going
just
to
said
they're not
that.
going to see something or understand. They're
So
just
few
going to
people
say,
understand that. Yeah.
why I'm expecting this, and well, you didn't look at the rest of the claim that had these codes on it and this modifier, which then says it's a 25% increase or a decrease, those
Yep.
types of things. You just can't take it for face value. You need somebody to go in and look at several claims to
Yeah.
try to see if there's a
I
pattern.
only hear that comment made by rev cycle people, because and a lot of people think finance and rev cycle, they like conflate them, and they are two very, very different disciplines. And one, you know, so there's while we were waiting for this to click off, I had one of my clients that I recently separated from, and we get along extremely well. It was a move that she needed to make. But she just reached out to me and she was like, but we can't figure it. Like things are going great. We've streamlined things the way we needed to, but the modifier situation, the denial, we need to have this stuff. And I think one of the problems too is, you know, so many of my competitors, I don't have respect for because they ship things overseas.
Right.
So like they go into the hands of folks who do not know any of the local payer landscape. And I know there are some states in this union, like I think Alabama has only Blue Cross Blue Shield is the only payer in the entire state. Massachusetts is a war zone. Like you have to keep up constantly on every single payer, and they're all jerks in completely different ways, whether it's modifiers, whether they're going to pay for this or not. And it's and I don't like I don't know. I'll advise people, if they're starting up a practice, like, you know, if you can manage things yourself and you only have like 3 or 4 CPT codes in your practice, you know, you're doing something pretty straightforward and you think you already know the game because you've had prior experience, then okay. But once you have, like, I have a sports med practice I'm working with right now. It is terribly complicated. And they were like, oh, the owner's thinking about bringing finance. I was like, you need me, or you need to hire a director of rev, not a biller, but a director of rev cycle, because a lot of the sports med stuff is cutting edge too. That they've become right now, like, when you were talking about like the late 90s, early 2000s, that was a very difficult time. That was in the rise of NPs coming in. That was hospitalists were just being created as a specialty right at that time.
Right. So at MGH, I mean, our primary care group were our hospitalists. And so they had two different tax IDs.
Yep.
And then it was, okay, now we're just going to hire hospitalists and let the hospital bill them.
Brutal.
Yeah. So
because PCPs were like, you're not going to see my patients. Remember, because in the old days, and no one's probably going to remember this now, but your PCP saw you in that hospital and they saw you every day, or they were supposed to anyway.
Yeah.
And like for those PCP, because I was on both, because I did a lot of hospitalist work, because after we did a lot of ED work, we did hospitalist stuff. And it was the convincing and the proving, and like a lot of the PCPs were like, I will be the last to convert. Let them take everybody else's patients, and understandably, they're trusting the care. They want to make sure they're going to get that update every single day when their patient was seen.
And it's funny because my father-in-law was a internist in Attleboro for a long time.
Over at Sturdy?
Yes.
Nice.
And then he became vice president of medical affairs. And then he went down to Florida and did that. But to watch him go from, his active practice to his leadership role to then being fully retired and watching the healthcare system, that we have all these conversations. When's the last time you saw a primary care physician enter a hospital? They don't anymore.
Right.
Now, I can't speak for out in rural areas, those types of things, but here, nobody does.
Right.
And they are just in their practice doing the things that they need to do. So I loved having conversations with him about the change of medicine. And he'd always send me articles. And I'd be like,
Sturdy was always like slow to change too. Like they didn't bring NPs in there, I think, until like 2010, 2015, before they even allowed NPs to work.
Yeah, Sturdy has been remarkable in its position in the marketplace. Because you talked about, Massachusetts, being a war zone. I mean, I came out of the New York City market, in New Jersey, where you had hundreds of payers.
Yeah.
And everyone said, oh, Massachusetts is different. Massachusetts is different because it had been dominated by Blue Cross, Harvard, and Tufts.
Sure.
Now the Uniteds, the Cignas, and the Aetnas are here. They still don't have they still have market share, but not to the levels that those three had prior. So, it was always different from the perspective of I wasn't dealing with as many PPO networks and because they hadn't been here. It's changed now in that market. But I think one of the trends that people have to get on quickly is all this downcoding that's taking place now.
You're talking about through E&M?
The E&M downcodings, from the perspective of people put the charge in and they're going to downcode it and they're going to contractualize it and it's going to come through a payment system and wipe it out. And so if you're not looking for those, all of a sudden you say, why is my revenue dropping?
Right.
And if you don't do that service mix to sit here and say, well, I'm saying I build out, 40% at level 4s, and all of a sudden it's now saying, and if you go and look and they downcode it to a 3 or even a 2, it's going to have dramatic impact on these practices. So, smaller practices can't afford a practice management system standalone, but their EHR may have a component where they can load some of their codes in.
Yeah, which is great. I think that there still has to be another step where it's, because if I talk to a clinician about what the difference is between a level 3, level 4, level 5, they're usually like, oh, well, but I did this. And it's like, right. So that to me speaks to acuity.
Right.
But what they need, there have to be 3 tests that you reviewed from someone outside your organization, or 3 tests that you ordered, or like some combination of 3 with these. And they're like, this is the game I have to play.
Yep.
Yes. Because they can downcode you legally if you don't hit that. And it's and a lot of them don't know. And sometimes there's like, these thresholds are easy to hit. All I have to do is say this, like, yes, say that, and then you're going to be fine. But
the problem is the payer's not even auditing the records.
Right.
They're just saying, I have targeted this and this specialty, and I'm just going to,
which is relative. What
downcode.
That was what, like 5 years ago they started that, maybe? Not even?
They started it, but it seems to be kicking back up.
Yeah.
I've been off the medical side now for a couple of years and went into the DME space.
Oh, okay.
With a medical device company. That was the therapy itself was amazing.
Yes. Yeah.
And what it does for patients with, tumor cancer.
Right?
Yep.
It's focused
glioblastoma.
on glioblastoma.
Glioblastoma is the major diagnosis
Yeah.
that, the payers cover. They also, can treat non-small cell lung cancer, and they just had a pancreatic launch where they have FDA approval,
Oh,
and
okay.
I'm hoping, it continues to do amazing things, but to me, I need to be constantly stimulated. My mind needs to be changing all the time, and my focus was very narrow,
Yeah.
and I missed my time with physicians and clinicians, and you
Right.
talked about MPs and PAs, and I mean, they have just changed the environment so much. I mean, I have a friend who's a PA, and he's also a professor, and what they're doing
Hmm.
is, incredible, and allowing physicians to do their research, their patient,
Right.
development. So, recognizing
physicians
the
are almost
impact they're
like
having.
really should be siloed almost to diagnosing, providing major
Mhm.
procedures in-house and stuff like that,
Yeah.
initial visits, and the nurse practitioners should really be manning all the minor procedures, subsequent, without question. I mean, sometimes too, it's like, I mean, sometimes I'll have a practice where they're like, where they'll talk about how their nurse practitioner is in high demand.
Yeah.
And I'm like, that's great. They're like, yeah,
Right.
but this is how, you told us they shouldn't be doing. I'm like, listen, if you have a nurse practitioner that's outperforming some of your MDs, then put them up in that spot. Like, have them be
Right.
the diagnose. If that's what they're good
Right.
at, like, I'm just telling you from a base model, there's like, you want your MAs to do as much as they legally can do,
Right.
to relieve the RNs, to do the same thing to relieve the NPs,
Yep.
and so on and so on. That's how you make a very efficient practice. But no practice is going to fall exactly into that mold. Like,
Yeah.
people are different. Like, we're dealing with humans here.
I have a great PCP, and he and I have a great relationship when I walk into there, and we talk about all the medicine stuff, then we talk the business side of the world.
Mm-hmm.
And so my experience with him is very different than a lot of other people.
Yeah.
Other people are like, I want to see the MP in the practice.
Yep.
Because they feel they're being listened to.
Yeah.
And the customer service level is higher.
No question. With nurses, it's always going to be
but
like
it's one of those things. And even with PAs, I mean, it's like the training's a little bit different. So
yeah, I feel like PAs mirror MDs a bit more. But then even like with MDs and ODs, you have differences. I mean, and then that's of course generalizing, and people are people. But yeah, I want to go back to Novacure for that's what it's called.
Yep.
Novacure.
Mhm.
So, I see exactly what I feel like. That's another job where if people know about what it is that they do, again, you could have conversations that could save lives easily with something like that, because that dramatically changed things. They aren't from the US though, right? Where are they out of?
So they're based in Switzerland.
Switzerland, right?
Yep. So they have the device. The Tumor Treating Fields is they are the only provider of the SERV therapy worldwide. And so they're in different markets all over the world.
Right.
So when I went in there, I made sure I touched base with the payers and made sure that whom I was dealing with at that time understood the therapy, why, it's billed the way it is. And it was just amazing. And I had the pleasure of meeting a patient that was wearing the device on the Las Vegas Strip one Saturday morning.
Yep.
And it was just amazing. Again, it made me feel like, I am
Like
benefiting the patient. Yeah. So, which is what I'm all about.
Yep. Wow. Yeah, but at the same point, I do see what you're saying, because the thing is, the things that I complain about most in this industry are the things that I'm most interested in. The more of a pain in the ass like an insurance company is, or something's like this payer is paying for it, this one isn't, or you have to do this for this one, you have to come up with all these matrices, and we'll like huddle up here and try to tackle something down. I'm sure you did a ton of that at MGH. It seems like hell, but it stimulates the brain. So like, it's a challenge. Like, do you want cookie cutter stuff, or do you want in life to be challenged with things?
Which I think brings us to transparency. For so long, you couldn't really talk about what payer A did versus payer B.
Yeah.
Now, because they have to disclose their contracts to the government, there's these companies that are just, filtering the data and selling it to people. And so you can see what everybody's getting paid.
Right.
So I think, has it leveled the playing field? Probably not. from the perspective of, hey, MGH is going to have way different services than,
Sure.
community hospital B.
Yeah.
Should the doctors be done separately? I mean, I still think you have to look at the intensity of the patient.
Yep.
And so, but it has definitely, Cigna can see what United's paying, and so I think it's leveled the playing field from that perspective, that
Okay.
now you can just kind of say, well, here's the acuity level of your patients. Here is what we think we should be reimbursed. Now, let's call a spade a spade. Healthcare costs are going up, not just from the clinical aspect, but from the insurance side of the world, rent, property,
Yeah.
all of those, they're like households.
Right.
They have all these fixed expenses. So there has to be some recognition. And I think, as insurance companies are just as important because they're employing just as many people, in communities, those types of things,
Sure.
as hospitals are, or physicians. Profit margins are very different.
Yeah, and I think, like you said earlier, nobody hates the person,
Right.
but sometimes we hate the company.
Mhm.
I mean, there are some things that some of those insurance companies do that, I mean, I remember when I was working in pediatrics, when I had my pediatric clinic, and they weren't paying for, like United wasn't reimbursing for adolescents to get their yearly mental health examination. It was something like, I forget what it was, Kevin. It was like $4 or $6 for them to fill out the form and have someone look over it.
Yeah.
And then so so all of a sudden it's like patients are coming up. Oh, we got a comment. Oh, we got a comment. We never get comments. I'll get to the comment in a second. So then patients got a bill from them.
Mhm.
And they're like, what is this? Why am I paying $6 for this thing? And I'm like, we're just going to eat it because your kid needs that. Like,
Right.
how do you,
Yeah.
anyone in a practice since past Columbine, are you going to have a situation where you're not just evaluating at least just once a year for an adolescent to see where they're at? And half of the time, like, they could have their disturbance at home could be sitting right next to them in that chair.
Mhm.
Like, and so, but you see that in like there are some specialties too, where it's like, they're just so oppressive with creating labor by, having medical records without real apparent need, almost like these across the board type of things. So like you're saying, like these pre-audits that are happening before they, like, without even having a reason to do it.
Yeah.
And I think that becomes more labor for all the people who work there. I don't think it's in the best interest of healthcare. And I think that, they have to be held accountable too. And it's hard because you just look at these places like United, and United will have like 30 different damn products. Like I wonder.
Well, products is one thing.
Yeah.
What has really become a problem is the number of companies they have under that.
Right.
Because they keep buying up all these different companies. So the Aetnas, you don't know who's really linked to your contract.
Right.
Until you start to pull apart issues. So, I mean, have you ever tried to deal with a UMR?
Yeah. Yeah.
The self-insured piece of United. I mean, they don't have public emails because they're not. And so trying to find somebody.
A phone number.
Exactly.
Email. Like, so they have, I think they have you can log in, and if they don't get to you within 5 minutes, it like times out. There's no referral number that there was even a conversation or it's a very poor service process that they have right now. And you would think, like, it would be one thing if they were these little poor boys in the market. They are the kings of the market, and they have the most garbage service. It's
but when you do find a contact at some of these places, you just have to kill them with kindness and really just be appreciative.
I had somebody before that worked here that sent because this is going back to like around 2010, and it was so hard to get somebody from Mass Health that stayed in that job for more than 3 or 6 months. And one of my employees, she got somebody great on there and was complimentary, respectful, and nice, not yelling. And then was like, is there any way that the company can get me like a $25 gift card to send to this woman? She stayed at Mass Health for like 4 or 5 years and was the best contact. It was just like, we knew the number, the extension, and we got everything done, because sometimes it's so hard to just find that good
those
contact.
were the good old days when you could do that and send gifts or whatever. Now I ask them for their supervisor's name, and I write a thank you, and say what the person did for us and how important to us it was.
Right.
And so
let me see if this comment has anything to do with what we're talking about here. We have Rebecca Hunt. Kevin has saved many a payer at Payer. Rebecca, little known fact, we had a contest to
I
guess
saw that.
You saw that.
Mhm.
And she
Yep.
got something,
Yeah.
a nice, apparently this TikTok company, amazing wood craftsmanship that they do at their
Excellent.
home.
Yeah.
Unbelievable. Thank you, Rebecca. So it's I don't know. It's a very difficult. So how hard do you think providers have it now compared to in the past? Do you think it's harder now? Do you think the landscape's easier? Do you think things have improved, or do you think they've gotten tougher?
I personally think they've gotten tougher from the perspective of trying to make their margins, because there haven't been dramatic increases, in terms of Medicare reimbursement. I mean, we all know where Medicaid levels sit. As more of these products to cover duals, or the Medicaid population, the costs are still there. But now if there's a PCP that, panels open, they could be flooded.
Yeah.
And it just changes the mix of their practice. So from that perspective, I think there need to be some guardrails put in, with terms of closing practices,
Right.
from the perspective of just protecting their bottom line. I think EHRs, have definitely helped from the perspective of coordinating information, making it more consistent, and those types of things. But that goes into the whole, how far can you take the physician from it, and
Right.
making sure the documentation.
Somehow it slowed documentation, which I did not see, because I believed in the idea of like the whole mandate of the EHRs. I like it because of the complexity, the thoroughness, like the comprehensiveness of the medical record, and the dependability, the easy access. But it's increased stress, which is increased burnout, and it's that's tough. I think that we live in a time too now, and I'd like to get your opinion on this, that it like, as far as eligibility checks are concerned, it is the most difficult environment that I've ever seen, because I mean, number one, you have a lot of like the hacking stuff going on, but you have so many mergers of these big insurance companies. Like when Harvard and Pilgrim merged, which I'm sure most people don't even remember that, but that was like a huge deal.
Yeah.
It was like, that was like a whole, but now you get this 0.32, and then they have their whole failure, and it's like, oh, when is one of the tough people getting migrated over, and the divorce rate you could even throw in there, how quickly people change jobs. It's people changing insurance companies has happened so often that, and I'm sure people get annoyed every time they go in that they get asked for their insurance card again and again. Like, I just gave this to you 3 weeks ago.
Right.
That's the environment we live in now, right?
Yeah. I think, as these mergers have happened, and it kind of blows my mind all the time, when NPI came, it was to standardize things. And so you didn't have to have unique provider numbers. Well, sure. But on the back end and the payer side of the world, they're still mapping to old codes, old provider systems. Like, they have not done what EHR has done to the front side, to their side, because IT's a lot.
I'm going to ask you a question that's going to reveal how old you are. You ready?
Yep.
What was it before MPI that was supposed to be the unique identifier?
It was their individual provider number within the company. The UPIN.
UPIN.
Yeah, the universal provider. Yeah. So I think the enrollment systems continue to be arduous. And I'm an advocate that you may not love the PICO system, but it is fairly organized, does collect the information that is needed. I think every state Medicaid plan should be using the PICO's data. It's CMS. So why do we have to have all these different processes on the Medicaid side of the world? And I think that should be the universal information that providers can take. Now they get into the whole credentialing, medical staff privileging. I think that's where, the NCQAs of the world and those types of things can help step in from the perspective of assuring that the policies and procedures are being followed. But I think PICOS should be a universal enrollment system.
I don't think I disagree with that. I think, I mean, at the very least, if there's going to be multiple systems, they need to talk. Like, a lot of people assume that PICOS and CAQH are talking to each other. They are not. And, and I think CAQH now has some auto-populate feature now, and you still manually have to check on that. That stuff is not foolproof. And I think it's important for people to know that as well.
I mean, there's no foolproof system. I mean, take AI.
Right.
I mean, everybody's using AI. The payers are using AI, so it's all going to just start butting heads. But if you take a simple medical policy,
Yep.
compare it to the provider note to make sure that as you go out from a billing, and I'm not technical by any means, and I can't build these things. I can only conceptually tell
Sure.
you. Before the bill goes out, let's run it against the medical policy to make sure that we have all the documentation that is needed,
Right.
and have that go out. If it matches the medical policy,
Yeah.
It should go. But if it's coming back and it's not, well, then where did it fail? So we periodically would do some comparisons between chat,
Right.
GPT, what they give you
Yeah.
versus what Copilot would give you.
Yep.
And they can be vastly different.
Mhm.
So you have to be careful with AI.
Right. Even the way your inflection, because it's like you're leading the witness type of a thing, because if you seem to indicate what your stance is on something, it
Right.
often will then try to make your argument for you and just make it better.
Right. Which is
terrible for something like this.
Absolutely.
Right.
But if you're dealing with some really complex diagnoses and some underlying conditions, those things have to be brought out.
Right.
So
it's hard, because it's like if you had that done on every single service being seen, you'd be worried that it would slow the process down like molasses,
Yeah.
It's so you have to keep it. You have to have a process that's streamlined, but also that it's not an adversarial condition. Like that would be ideal, right? Like if it wasn't us against them type of mentality of like the insurance companies are doing everything they can to not pay.
Yep.
That's how they can run profitable.
Right.
And so we have to play their silly little game of modifiers and all these little things to try to make sure that we're maximized. And no one ever is going to think that they're getting paid properly, because you're losing. Where are you leaving it on the table? How do you limit that? It's just a never-ending conversation.
Yeah. So, I mean, my experience, and I'm just going to digress a little bit. When I was at MGH, I got more calls from payers saying, "Can you help me get somebody in to see somebody?" I was like this little referral agent, so to speak. And, that definitely helped my relationships.
Yeah.
There's no question about it. And, for a while I was involved in their international business and managed the single case agreement process, the workers' comp. And so I was always talking to people about, here's why they're coming here.
Right.
And here's why, we're charging what we're charging. Now they can get services pretty much anywhere virtually.
Right.
So it does change the dynamic somewhat.
Yeah.
And,
depending on demand. I mean, PCP stuff is really hard right now for people. But yeah, you're right. And so let's take, and you've always been a big, like we were talking about some human resource stuff a second ago too. You've always loved managing folks, right? Like it seems like to be a passion of yours.
I like developing people. I like teaching them. I like to take what's up here, because I am not a tech person. I am, look, I tease everybody. In my first job at Blue Cross in Massachusetts, I had an admin. Back then they were called secretaries. She left me notes on while you were out, so-and-so called, and the phone number, and we worked on triplicate paper. The fax machine came in, somewhere after my first or second year.
Yep.
But, the filing systems were huge. I didn't get email until I'd come up to Caritas Christi and started working on Lotus Notes, which was a foreign concept. But so I never grew up my career in the digital. So my Excel skills are fairly limited. I've gotten better, but I don't do detailed spreadsheets, that kind of stuff. So I just, let people teach me. But then I'm like, here's what I need.
Right.
So I have always enjoyed it. The managing of people, it could consume your day. It could. And I've had some very difficult situations that I've had to deal with that I didn't like at all. I do not like conflict. I do not like people being mad at me. But, when you have somebody throw stuff at you or things like that, it's just...
See, I like conflict. I feel like you can get, I don't know. I think when you bring things to a head, like they need to be brought ahead, because you never want to have the office that everyone's walking in on eggshells.
Yep.
And when you sit somebody down and say, hey, listen, here's like what's going on, and then you get their side of it. And I think it's like, I've never been one to compromise. If someone has a better idea than me, let's go with that. I'm not I don't have the ego for stuff like that where it's like, you need to go with my idea, because I don't really do anything the best here. Like my billers are going to bill way better than I can. I mean, I try to get myself into it a couple times a year and stuff like that, but I'm never going to be as good as anybody here. So chances are they should actually probably be better than me at a lot of the stuff.
I would hope so. And then, but you're providing them the environment for them to continue to do their job. Which, so from a strategy standpoint,
that's tough.
That's important.
Yeah.
I have always tried to be consistent and,
not pick favorites,
which is sometimes hard to do. I mean, I have fallen prey to it, but again, I've had a couple bad situations where, I didn't listen to my team. I made a bad hire and we dealt with it, but then made me deal with everybody the same way. And so it wasn't a comfortable period, but it was one that I had to. So, and I had to start calling people out, and I started to have to say that's not appropriate.
Would you do it publicly, or would you do it privately for the call outs?
Some of them would be, we'd be in a meeting and I would say that is inappropriate and we're not going to talk about that at this time.
Right.
And then I would follow it up afterwards because I needed somebody to hear that I was telling somebody else that was not appropriate. Yeah. So I didn't get it after the fact,
Yeah, if I'm doing like a staff meeting, I see two people talking, I always have to call it out. That gets right under my skin.
Yeah. I mean, I can be guilty of that, but at the same time, I try to be cognizant of it and stop myself, those types of things. I mean, which these things have made it virtually impossible. Somebody be sitting there, they act like they're listening, but they're really doing something else. And so that's always frustrating. I have two boys that are in the service industry and they are leaders in their profession and their job. They have people under them.
Okay.
And as my youngest just started a new job this week, I just said to him, you just have to be consistent. Try not to fall into that, I treat so-and-so this way and so that way. Yes, you can lean on this person, but at the same time, you have to be consistent. So if you let him have a day off, you got to let this person have a day off,
Right.
And just make sure that it is extremely hard.
Right.
But, you get somebody to sit there and who go to HR and say, he treats me differently, and that's the last thing that I ever wanted to deal with.
Right. Yeah. But I think also like, if I'm speaking with you about, even if I had the same conversation with you that I have to have with somebody else, I would still tailor it differently.
Right.
Especially if I know you well, then I'll be like, I know what Kevin's receptive to. Kevin doesn't want me to start this conversation out with, hey, you're great at this, you're great. Tim, just tell me what's going on. What's the problem, right?
Yeah.
That's how you would be, I would assume. Whereas other people are not geared that way.
You have to massage it and you have to.
And so in that way, I feel like, so I guess you can kind of do the same, both, like get the same message across, but to be good at on the management side, you do, I think, have to tailor it to the person. That's probably like a pretty controversial way to do it. Some people probably don't do it that way. They do it the same way. I would imagine legally, you're supposed to give out a same damn note to each person.
Yep. And I treated my relationships with payers that same way. And somebody described me. I was not present at the meeting. They were introducing the new rep on the MGH side. And they said, well, Kevin, who's not here, he's a great guy. He will participate in the meetings. He will get on his soapbox. He'll grandstand and he'll make you feel like there's a big problem, which there probably is. But when he sits down and pushes away from the table, he's a human being. He is the nicest guy in the world. Right. And so, which is probably, I'm a Virgo, I'm sensitive. And I don't like conflict, like I said. Yeah. But at the same time, I have to push my message. If my wife listens to this, she's gonna be like, you're full of shit. But, she's like, why can't I get you to do that? But, it's how I treat people, and I just try to do it consistently. There are people I don't like. I mean, it's just natural. But at the same time, I realize it's not them carrying, they're just carrying the message.
Sure.
And I have to just let it go.
Or if they're really good at what they're doing, it's like you deal with it. I mean, they deal with you, you get it.
Yeah.
Now, you have a bit of an announcement to make here, don't you?
I do, yes. As everybody who follows me, on LinkedIn knows that I have been looking for that next opportunity, and I continue to look for that next opportunity because I am someone that likes to attach themselves to an organization. But I have started Mulcahy Healthcare Advisors, focusing on small practice individual providers in revenue cycle, provider enrollment credentialing, contract management, and payer relations. And so I'm really excited about that. And it's just me. And, I'll engage people if necessary, but I'm really looking forward to reconnecting myself with providers. It's something that I've wanted to do as I prepare for retirement, because I know I'm not going to be able to sit still. When I retire, that, I've always said I will create a company, an organization, I should say, that will allow me to do these small projects. And I've done them. I've had some great friends, while my boys were in school and that kind of stuff to help me, tuition payments, all those fun things. And so I've just kind of, but now I'm kind of free to take on cases that I normally might not have because of who I was associated with.
Okay. And so for whoever might want you for this, how do they contact you?
So my phone number is still the same, but mulcahyhealthcareadvisors.com is live as of yesterday, and I will post that shortly. I'm trying to figure out, you can contact me and it will go to my email. And, I'm really excited. I am working with a client right now that's involved with Medicare and the QIO program. So I'll be reaching out to a lot of my friends to sit here and talk to them about the program.
It's good. That didn't take long, huh?
No. And that was part of that whole networking process. For those of us that are older and from large families where you have a family network, I had put something out to my nieces and nephews and my children and said, here's what's going on with Uncle Kevin. And, and, they all responded and they all had ideas and they put me in contact with people. And so I'm extremely appreciative of it. So you have your work and your family.
So there must be times too where it's been difficult. Like, have you looked at the mirror and had doubts about this stuff, or have you always been confident through this process of looking for your next step?
I'll be honest, most of the time I've had the unfortunate but fortunate to be in this multiple times.
Yeah.
And it has always led me to a better place.
Awesome.
And so I try to, my wife Jen keeps me, we will come out the better side of this. And so now it's just, again, I am in a different place in my career.
Sure.
I am not looking to, be the vice president of this or that. I just, I still have bills to pay and, we'll do that. But I have looked in the mirror. There are days I have self-doubt. The recruiting side of the world is so different now.
Yeah.
It's, unless you really know somebody to push you, the ghosting is a feeling that, unfortunately, Jen doesn't know what she's going to get when she comes through the door from school. If, I'm in a good mood or a bad mood, those types of things. Because there have been some great opportunities that I've looked at, thought I would go in, to the pharma side of the world, but I don't think I want to go into the pharma side of the world anymore. And that's why I've re-energized myself. And, I do have a little bit of a niche in terms of payer relations and those types of things. A little bit, relationship management, that it's not for everybody. They don't understand it, but if the right opportunity comes along, I'll be ready. But in the interim, Mulcahy Healthcare Advisors is open for business.
Let's go.
Let's go. Yeah. So I got to thank a whole lot of people, in this process. You immediately called me when you saw that, I was in this. Julie Sylvester, called me and a whole lot of people have outreached to me saying, how can I help? You know, my MGMA friends, Taya and Kem and Claire have been right there with me. And, you know, there's been this whole big thing between HLA and MGMA, and I'm glad to see that, you know, there might be some things happening to, you know, align them. But, you know, my MGMA friends have been great. My HLA friends have been even greater. So I'm excited about the future.
Good.
But I'm a people person, and I need to get out from my basement and engage again. So
yeah, it's I think like the job search stuff, and I'm sure. I mean, number one, I thank you for opening up, because I don't really see anyone ever being candid about that. And I think it's a very difficult thing to talk about. So I wanted to thank you for coming on here and saying that. And like, I remember the last time I was hiring here, even entry level, I had 150 resumes and I just cut it. And I brought in I probably had about 30 or 50 I thought were really well qualified. I probably had about a dozen that I interviewed. And I remember when I talked to, you know, so the people who get further down, I make sure to have a conversation with them if they don't make it. And the person who finished second, she was like, I can't believe that I missed out on this opportunity. And I was like, you beat 148 out of 149. If you were a boxer and your record was 148 and 1, you would be better than I mean, I wouldn't say Rocky Marciano, that's the best boxer of all time. But, you know, you'd be way up there. It's an elite finish. I was like, you easily, we had to choose one, and it was between the two of you, and it was close, and we had like a tough decision to make. It's and I think it's impossible for people. I mean, you know both sides of it, but I think for a lot of people, especially folks who don't know both sides of it, and I hope that that anybody that's looking can think about this, is that it's not personal at all. And I know that sounds kind of shitty to say, but the reality of it is that, like, when you have numbers like that coming in for folks to interview, like sometimes it literally is like, you just have to go on X amount of interviews, especially if you're a good candidate, you have the right attitude and stuff like that, and you're going to land something eventually. But it's not an easy process, and it's not a fair process either.
Yeah. I had, right after I'd left Novacure and, you know, I was starting this process, you know, my network, you know, somebody called me and said, Kevin, you know, we're recruiting for this position, you know, and I went in and I interviewed, and I almost wish that it had happened like a month or two down the road, because I was so nervous. I wasn't ready. I was, you know, because it's to be 60 and interviewing, and, you know, it's a different mindset. And, you know, so it's like, I hadn't really developed my most recent story to talk about some of the accomplishments and how I could really help them. And so from that perspective, you know, ultimately my understanding is they closed the position, but I wish that, you know, it happened just a little bit later in my search, because I'm in a different place now where I know what I want to do and, you know, how I can help people. But there's hundreds of people going for these LinkedIn job, you know, these postings on LinkedIn. And sure, I looked at it, but then I go and start looking at who's connected to whom, and, you know, those types of things, and start to work, you know, avenues that way. And I've, you know, had somebody who I only knew in my short career at Novacure, who I become friends with, you know, who's sending me leads almost every day now. Are they viable? That type of stuff? No, but she is, you know, just keeping me, you know, going from the perspective of looking and positioning myself. But now I have a new focus that, yes, I will continue to look for it, but I am putting, you know, my, what's the word I'm looking for? Put my weight behind Mulcahy Advisors.
I love it. I love it. And I think that's you kind of like taking control of the situation, and that's great. And I think I've seen other folks do similar things. Oh, you know who you'd be great with? I should introduce you to this friend of mine, Steve Dancy. He's a fantastic networker, and he's kind of like he has like a rent a COO type of business. He'd probably punch me in the face if he heard me describe it like that.
Yeah,
but he's cross industry. He's helped this place out. He's done work in like food and beverage, but he's been a fantastic person to know about, like, the landscape of Massachusetts business as a whole. He's a fantastic connection to have too.
And sometimes just talking to somebody, you know, and just grounding yourself, saying, do I have this right? You
Right.
know, like, and that's what I did. You know, somebody introduced me to somebody that was in the pharma industry, now retired. And I'm like, why doesn't pharma see that payer relations is like market access? But because I
Right.
don't have market access on my resume, I don't get
You're gonna get
noticed.
overlooked.
And he's like, it is the same exact thing, maybe a little bit more of a marketing
Right.
spin, but you know, it's like, okay, this is what I do.
We have another comment to hit here, but it just reminds me of, like, you know, because I think we all have regrets. I remember the first time I ever got into sales. So we've had one layoff session
Mhm.
ever here after 35 plus years. And it was the worst moment of business for me. There's
Mhm.
nothing worse than telling somebody that they cannot work. You're cutting off their lifeline and they did nothing to deserve it. That is disheartening.
Extremely hard.
So I've tried to do everything from attrition after
Mhm.
that, and it's worked well. That being said, I remember I went to he's a podiatrist right down down at the old oh god, what is it? It's right on the Stoughton Brockton border.
Mhm.
And I actually worked with him a little bit with my PD practice, which is great. And he used to be a neighbor of mine. So I stopped in and I talked to him, and he tells me about his setup that he has one person doing all of his billing. They work in an island off the coast of Florida. And I basically was like, sounds like you have a great setup. Best of luck to you. Or something
Mhm.
like that. I'm like, I didn't know
Yeah.
at all how to sell this business. And I met with a real estate guy, and he was like, I don't even know. He was like, what is rev cycle mean? I have no idea what your industry is even like.
Right.
Within I was like 2 or 3 minutes into my description of it. And he was like, oh, he's like, so basically what you would say to somebody is blah, blah, blah. And then he sold the company better than me, who has been doing it since I was a child, could. And that's
Yep.
when I realized
Yep.
it's not about knowledge. It's a way to
It's the
talk
way
to
to spin
people.
it,
Yeah.
So
All right. We got another Rebecca Hunt here. What do we got? Thoughts on this scenario? Private practice, major contracts, Blue Cross Blue Shield, Point 32, etc. Going through the MCN we belong to. Smaller contracts are private. Hospital does not contract with UHC commercial plans, but I do. Why do I bother? I can't do surgery on them. Why can't/shouldn't I just fire UHC? I need to read that again myself. Hold on. Did you get the question there?
I did.
Okay.
So, I mean, Rebecca, what from you know, are you getting high volume E&M, and then who are you referring them to? You know, is there an AM surge center that you can start to take these cases to, as opposed to the hospital? Because they're going to really want you to go to those AM surges for those things that you can. But yeah, if you can't get that lucrative business or that business that's going to grow,
Oh,
drop
she's
'em.
saying she's having trouble with United Healthcare?
That's what she said.
Okay.
United, yeah.
Yeah, well,
So-
yeah, that is. I can't tell you how many people I have steered away from them just
Mhm.
because of how punitive they are. And
Yeah.
I mean, I beat the crap out of them when I can. They've made things very difficult in the industry in Massachusetts anyway. They're very difficult to deal with.
Yeah.
We'll see if she responds. She has to type in here. We'll have to get like a chat thing. But yeah, and I think that's it. And I would say, you know, Harvard Pilgrim's very difficult to deal with as well. There's, you know, I think everybody has their trouble. Like, you know, I was talking to somebody the other day who was really pushing for universal health care. I don't know how you feel about government insurance versus private, but I mean, I think they all are very difficult and often not really great in just different ways. I mean, I think we have, you know, most recently I heard we have about $100 billion in fraud per year for Medicare, Medicaid is what's being estimated as a minimum. I mean, neither program has ever really made money.
Yeah.
Like, they've done well with FQHCs. I think the government doesn't do a lot of things well, but FQHCs has been a maker.
Yep.
But Medicare and Medicaid, they've had a lot of trouble. And the thing too is, some things I think they do poorly, but a lot of things they have the best intention for. But it is hard to do something that consumes the entire market, like how you were talking about earlier with. Hold on, we got a response. I'm gonna shut up. The ASC we could work out of is owned in part by the hospital. I really just want to fire UHC, and I'm trying to justify.
Yeah. I have gone back and forth with regards to universal health care. And, you know, early in my career, I was just like, well, we'll just create the black market insurance business, which exists in other parts of the world.
Yep.
I'm leaning more towards universal health care because I've watched it in being part of an international company.
Yeah.
So I would always talk to those people that had,
Right.
sponsored healthcare. And then my brother-in-law spent a couple of years in London, and like you said, layoffs and those types of things. And he said it's just such a different attitude. They're like, okay, I'll just go to my next job, because unlike us,
Right.
they're not worried about healthcare
Right.
because they have it.
Yeah.
Whereas I'm sitting here saying, okay, I'm on Cobra
Yeah.
now. I got this huge bill coming at me, and I got to plan for it.
Yeah.
That it's almost like maybe if we did adjust and it
Right.
became, a benefit, that our lifestyle might be better. What's the expression? Americans live to work, and the rest of the world work to
Yeah.
whatever
Yeah.
it is.
Well,
It's like work-life balance is totally out
It's
of whack.
really, yeah, you're hitting the mark there. I think a lot of people have a lot of distrust for the federal government. I think that's a difficult
Mhm.
piece too. And I think it's very well validated. There's been lots of mistakes made by the federal government, but even within medicine, there's been mistakes made in medicine over the years too. It's human nature. There's corruption, but then there's honest mistakes being made. So it's hard. I always like there to be multiple voices. I hate the idea ever of there being a solo institution for
Mhm.
anything. Like even for like the pharmaceutical industry right now, all the drugs basically get manufactured in one place. I don't ever think that that's a healthy situation for really any industry to have.
Mhm.
But we'll see. There's I recently did this. I recently found out a couple days ago, I think, that there are still hunter-gatherer humans today, which I didn't realize. You know how many hours they work per day? Oh, 2 to 2.5 hours per day.
Mm.
They spend, I mean,
Yeah.
there's trade-offs. I think
Yeah.
it's 4 out of every
Yep.
10 children don't live past 5 and things like that. But they spend all their time with their family. They don't really celebrate people who brag much,
Yeah.
or like everybody's kind of treated equally. They don't have leaders per se. They all are like, the women do all the gathering, so they're like really celebrated because they bring the food every day.
Right.
The men will score on a hunt once every 4 days or so. And that's great. We can eat protein. It's just, you just see there's so many different, so you talk about like the work-life balance, and not that we'd ever take something like that on. We've decided to create a place where we have bosses and we have all this stuff here. And
Yeah.
so I'm sure in some countries, universal healthcare is ideal too. For smaller countries, maybe it would work on this level too, because there's larger countries than ours that seem to pull it off. I feel like we could benefit a bit more from some Eastern medicine stuff, where I feel like they're better at being proactive for like preventing, because we have the best medicine in the world here, I think, but we also have the sickest people in the world here. Like we do a lot of reactionary type of stuff,
Yep.
whereas like the proactive stuff is not really hit here as much as it has in Eastern medicine, and it's been there for much longer.
It's funny. We went to Italy last summer, and as I observed the older population smoke, drink, do all those things we're not supposed to do, and they are loving life. It's like, so it's, what are we doing wrong over here?
Right.
And I think it's, we can talk about our foods and everything else, and but it's that work-life balance that we don't prioritize.
Yeah.
And that's what I'm learning. And so,
yeah, there's a lot of great things that have come from all the work that the people here do. The productivity is like unmatched, and we lead the world in many great things. But you also have the highest rates of depression and mental health illness here. You show me like somebody who has no challenge in life or is born from money, I will show you one of the most racked brains when it comes to depression and things like that. It's challenge is good. And
it's we're only seeing a little bit of the effect of COVID on the young children, and there is some stuff, but just general mental health, stress, depression,
right,
it can happen really fast.
Right.
And you'd ask me about self-worth and do I ever doubt myself? Absolutely. And then I'm like, okay, let's get off this train.
Right.
You know, because it can
Yeah.
happen so fast. And
you can come out of it fast too. And that's a tough
Yep.
thing when you talk about like things like suicide and stuff like that,
Mhm.
is that, you know, so I mean, I've known a few people where I'm like, oh my God, if they just held out to the next morning, and because things would have been different because of such and such. It's a, but you know, when you get into that, because I would imagine most people have been depressed, like terribly depressed, but they've at
Mhm.
least contemplated it. And you know, everybody's always like, hey, reach out to people. It's like when you're in that state, you don't think anyone gives a damn about you. You're not reaching out to anyone. You are stuck in here,
Mhm.
and and you're in a match against yourself, and it's only up to you to come out of that sometimes.
Yep.
Like there are so
Yep.
many resources for people, and I love it. Mental health has come a long way, has a much greater way to go, but it's still like a very internal battle.
Yeah, it's doesn't carry as big of a stigma when it's, you know, there's some, you still watch people or look at people and say, oh, you know, but
Yeah.
when it's happening to you,
Mm,
it's a very different story.
absolutely.
Or watching your children
Right.
deal with
Oh,
these
God, yeah.
issues. And, you know, I just continue to be in awe of my sons. I mean, and where they have come in their life and the challenges that they've had.
Mm,
And I'm like, wow, because I came, you know, Jen and I kind of laughed because if you listen to a lot of the music that we grew up with, we were taught to suppress our feelings,
yeah,
to not share.
of course.
We were supposed to be these you know, like the world is a wonderful place, but inside. Now, you know, I'm sometimes like, okay, that's too much sharing. I don't need to know that, you know, those types of things. But that's this generation. They're all about sharing and my feelings, and this is what I want. And,
Yeah.
and I'm like, okay, we got to find a balance, you
Right,
know.
right.
So, and I can't even think, you know, the song "Don't Cry Out Loud."
I don't think I know that one.
You don't know "Don't Cry Out Loud"?
I don't think so.
Okay, I'm not going to sing it, even though I could, but it just talks about, you know, not opening up and, oh, you know, don't cry out loud.
Okay.
Just keep it inside, all of those things.
Yeah,
And my
yeah.
wife and I, you know, a couple of years ago, we were just like, wow, that's how we were raised.
Yeah,
And
absolutely.
so it's so different now.
Right.
And that's where I think we, you
I
know,
like it that some people are courageous. I've had people walk in my office and tell me some things that I would never think to open up about, but also it's like, now I understand what's going on with you. So,
yeah,
you know, and it makes me understand like why maybe we can create a carve out for you here in a way that help you with such and such. And
yeah. And being able to recognize um, when people say something and picking up on it,
yeah,
because there are a lot of people, like, you know, you can sit there and say, you know, here's what I'm dealing with, you know, and, you know, triggers and, you know, there's
you never know. You're walking on landmines. It was one time
Mhm.
we had some like internal thing with this bake off thing, and I came out and I was like, oh my God, I was like, I need to go into the bathroom and purge. Little did I know that it was 2 years to the date that one of my employees had lost their mother who had like bulimic issues.
Yep.
Like, how the hell could I have
You
known?
don't.
But at
You
the same point,
don't.
somebody was like, listen, you don't have to talk to her. I'm like, I'm talking to her right now.
Yeah,
I was
yeah.
like, listen, I
Yep.
obviously didn't know. And she was like, it's
Yep.
okay. It's fine. I
Yep.
was like,
Yep.
believe me, I'm just going to tell you, I will never make a joke like that in front of you ever again. We all have
Yeah.
our own sensitivities.
So
Awesome, my friend.
Thank
this
you.
was fun.
This was amazing.
and so easy.
Yep.
As I expected it to be. So best of luck to you out
Thank
there.
you.
For the
Thank
folks
you.
at home, check out, what do we call it one more time?
Mulcahy Healthcare Advisors.
Mulcahy healthcareadvisors.com.
.com. Yes.
Check them out today, tomorrow they're launching.
We are live.
Okay, we are live now. Oh, what did I just do? All right, guys, thank you very much. We'll see you at the next one.